Assalamu alaikum and good evening, dear participants. Welcome you all in today's ECG lecture session. Today is our 82nd episode of lecture series organized by ECG Study Group, ECG Basic and Beyond. And topic of today is the supraventricular, is the wide complex tachycardia and supraventricular versus ventricular tachycardia. This will be provided by none other than great electrophysiologist, Professor Dr. Rafiq Ahmed sir. Before start of the session, I'd like to request Professor Abdullah Jamil sir to speak about Rafiq Ahmed sir, and then we proceed. Abdullah Jamil sir.
Thank you, Tushar. Assalamu alaikum and very good evening to everybody. Nothing to mention new about Rafiq sir. It's since 2004 I know him and learned so many things from him. He's an excellent teacher, and the criteria of an excellent teacher is to deliver a complex thing in a simpler way so that a mediocre or even less talented people can also learn many things. So I don't talk much more. Let's start his lecture. Rafiq sir.
Thank you, Jamil. I have taken the liberty of changing the topic a little bit. I thought that I will do 1 or 2 lectures on arrhythmia. And I thought that this will be a good topic to start in the beginning of the year. And what I'm going to talk about is mechanism of cardiac arrhythmia. In a very simple way. I mean, I like, as Jamil said, I like simple things. And if we know the simple bread and butter stuff, then the complex things can become easier to manage. So this is Bangladesh. I mean, this is our land, and I always feel that we are indebted to this land, and we have obligation towards this land and to take care of the people. Of course, we have to make a living also to have a better life. So just the anatomy of the heart. If you look at, this is looking at the heart from the right side, you can see that the sinus node is at the junction of superior vena cava and the right atrium. It's a long structure. It's not a small dot, as we used to imagine when I was a medical student. It's a long structure, about 1 inch long. And then the atrial tissue, and some people believe that there are some connections between the atrium, between the sinus node and the AV node, which has not been proven electrophysiologically or anatomy histopathologically. But there are some preferential conductions. And then the AV node, again, the AV node, we always consider it as a round structure, but actually it is not as round as we think it to be. It's kind of, it has fenestration. It has a central fibrous body, and then there are fibers coming down on this side, which is important electrophysiologically because that's where the slow pathway is. And then we have the His bundle. If you look at it, it gradually goes upward a little bit. And then it splits into right bundle, which goes along the subendocardial tissue and then through this moderator band into the right side of the right atrium. And it conducts very fast. And then on the left side, this is the wider left bundle. And what it happens, it splits into 2 fascicles, anterior fascicle and posterior fascicle. And so left anterior fascicle and left posterior fascicle, and then it ramifies. And the electrical conduction happens through this conduction tissue, and it's very fast. And that's why when we do an EKG, it's narrow. However, if the electricity had to go through the myocardium, then the ECG will become wide. That's what happens in ventricular tachycardia. And also in bundle branch block. In bundle branch block, it partially goes through the bundles. Like if somebody has a left bundle branch block, the electricity will go down the right bundle and then through the myocardium into the left ventricle. And that's why the left side electrogram will show wide QRS complex. So histologically, see, this is the cells. You have myocardial cells, and then this is where, and it's a syncytium. Syncytium means they're connected to each other. Other places, the cells are separate. If you look at the nerve cells, they are separate. They are not, they're connected with each other. But this is syncytium. And then what happens the way, if you look at this is the muscle fiber, and then these are the connections between the two cells, and these are called intercalated discs. And this, I mean, when I studied anatomy, I did not think much about it. But as time passes by, we are finding out more and more about these structures and the pathophysiology and the role they play in different disease processes. So this is the intercalated disc. You see, this is the connection. You see electron microscopic view. And if you look in the, so this is one cell and other cell, and the connected by these proteins, desmoglein, plakophilin, and these are important because we can have problem with this and cause different kind of disease process. And I'll just give you a summary of this. Look at this. If you have this one is important. Plakoglobin. Plakoglobin is this one. If there is a problem, and that is what is connected to arrhythmogenic right ventricular dysplasia. And then desmoglein, arrhythmogenic right ventricular dysplasia, dilated cardiomyopathy, catenin. So these are all the things that we are finding out now. And the importance of finding out about this and knowing about these things, that we can then target the therapy of this. So I think you don't have to remember this, but please try to understand these pathophysiology processes, because by the time I retire, it's unimportant. It's not that important, but by the time all of you younger doctors will retire, these things are going to play a significant role, how we diagnose these diseases, how we treat these diseases. So it's good to get used to these structures at a microscopic level. So this is actin and myosin. As you can see, this is basic anatomy. These are actin filaments, and this is myosin. And the way it contracts is this, that this myosin filaments, they attach to the actin, and then they pull the myocardium to contract. So if I go back here, so this is there is a gap, and then when this myosin will attach to this actin and it will pull it close, and that's how the myocardium contracts. So this is myosin, and the myosin has different structure. Myosin head, there is light chain, heavy chain, myosin neck, and this is the myosin band. And there can be disease process, and this is troponin, different type of troponins here. And as you can see, that there's a different kind of structure. So that the myosin, light chain, heavy chain, myosin neck, and there can be disease of all these structures, which is very much related to hypertrophic cardiomyopathy. What happens that these structures become kind of inefficient, and then myocardial try to contract, and it causes abnormal force generation with compensated hypertrophy. Unfortunately, what happens with hypertrophic cardiomyopathy, if you look at these structures here, this is the normal myocardial cell, longitudinally oriented, and little fibrous tissue. But in hypertrophic cardiomyopathy, you can see that myocardial fibers are not longitudinally directed. They are going in all directions. So they, even though it is hypertrophied, it is a poor quality structure for cardiac function, because it cannot contract very well in a longitudinal direction. This hypertrophy is different from athletes. So if somebody is exercising, it will happen, their fibers are not going to hypertrophy in this way. It will be longitudinal hypertrophy. So it's a little bit different. And same thing will happen in patients with hypertension. So those are not much proarrhythmic, but this one is proarrhythmic because there is this area of the myocardium, there is fibrosis, and it produces scar tissue. And again, if we look at it, that there are different kind of beta myosin heavy chain defect, cardiac troponin T defect, and different kind of, this is actin and myosin filament defect that is causing these arrhythmias. So if you look at these, at a molecular level, action potential is what generates the electrical activity. Now, some of the cells in myocardium have spontaneous depolarization ability, such as the sinus node. And if you look at the sinus node, action potential is kind of sinusoidal. AV node also it has. But if you look at the atrial muscle, normally they do not have ability to generate its own impulse, because what it means that when you see this straight line, that means something will have to stimulate it. And what happens? Electricity from the sinus node will go into the atrium and generate this action potential. And then electricity will conduct through the AV node and then stimulate the ventricular tissue to produce this action potential. And we end up with this QRS complex. So this is the P wave, and then it goes through the AV node, no signal, and then QRS complex. So normally, the cells are positive outside, negative inside. And when it is stimulated, and when sodium comes in, inside becomes positive, outside becomes negative, and during depolarization, then repolarization, it goes back to the resting state until the next stimulation happens. How does it happen? We have, this is the cell membrane. If it's a bilipid layer, we all know this, and there are pores in the cell. And these are very important structures, so that we need to understand them a little bit as much as we can. And what happens with these pores, like if we look at this sodium channel, it's closed in resting state. So nothing can pass through it. So if there is a stimulation, it will open up and sodium will gush into the cells. And once there is a certain level, there will be inactivation by this blocking gate. But that's not a permanent inactivated sodium channel. And then this one will block it and then stabilize the inactivated state. And this is how it's happening. So, and this will happen, and this will remain closed, and until the next stimulation comes to produce this thing again. Now, if you look at this is a calcium channel, again, if you look at this is resting state, opens up, calcium comes in, and then closes. Look at how it happens, that calcium channel blockers, a different kind of calcium. Verapamil works here, diltiazem works on this side, and nifedipine works here. And that probably explains why the mechanism, the effect is different. So just by changing the location of where these drugs work, it defines how they're going to, like verapamil is a potent antiarrhythmic and also antihypertensive. On the other hand, nifedipine has no antiarrhythmic action, and diltiazem is somewhere in the middle. So do I always remember these things? No, I don't remember it, but I know the concept, and the concept itself is important. It's just like that modern day medicine is so big that we need to know, yes, there is something available, and can I find that information somewhere? So that if I need, I look it up. And I will also suggest that anytime you write a medicine, try to read about it a little bit, find out how it works. Where does it work? Does it work at like antibiotic will kill bacteria, but other medicines work at different level, at a cellular level, like this calcium channel blocker, how it is working. Now, if you look at the action potential, that when cell is stimulated, the initial part, sodium goes in, and from negative, it becomes positive. Usually 0 is around here. And then sodium continues to come in, but there is outward rectifier current. And subsequently, what happens, the sodium calcium doesn't come in anymore. Potassium goes up very fast because there's a lot of potassium inside the cell. And then sodium also keeps being pumped out at the same time. And that's how this comes down to the baseline. This picture, just try to, it's a little complex picture, but what it happens is it took me a long time to understand this. What they do, they try to represent how, if this is the line, this is inward current, this is outward current. And if you look here, this is sinus node action potential. So here, there is a funny current. This is the diastolic potential. And the funny current, which is a combination of sodium and potassium, gradually increases from -65, goes towards positivity. And as soon as it reaches a threshold potential, it starts the action potential. At that point, there is massive influx of calcium. So it is the atrial cell, the action potential is very much calcium channel dependent. And then to bring it down, there will be outward potassium. And then again, to start the cycle again, this is funny current that will coming. And this is funny current is very important because we have a new drug, which is available in Bangladesh and United States, ibabradine. It works at this level, this works the funny current. And here is the action potential of the ventricular myocyte. Ventricular myocyte cannot generate impulse on its own. It has to be stimulated by, as soon as it is stimulated, sodium comes in, and then followed by potassium coming in. But at the same time, to bring it back to normal, we will have massive outflow of potassium, and then gradually there is stabilization. So these creates different phases, phase 0, 1, 2, 3, 4. So let's look at a condition like if we have long QT3, what happens? There is problem with the sodium channel. And the sodium channel takes long time. It keeps persistent sodium current. So it is activation of sodium. So sodium channel was supposed to close up here so that it doesn't let any more sodium come in, but it continues to let sodium come in and it prolongs the action potential.
I think yesterday we gave them verbally that
Prolongs the action potential. And
so how to order like respiratory therapy is 2 liter.
Can you mute, please?
Kamrul, please mute the others.
So this is just a simple example. Long QT3, there is problem with sodium channel. It prolongs the action potential, and that prolongation can lead to cardiac arrhythmia. So if you look at this, so long QT syndrome, long QT3, there is more activity of the sodium channel. In Brugada, there is negative. And then other kind of long QT, long QT2, long QT6, these are all potassium current problem. So try to understand them, and that will help how we can treat these patients. So mechanism of arrhythmia, there are basic couple of mechanisms that we talk about. First 3, enhanced automaticity, after depolarization, which can be early or delayed, and re-entry. And there is another mechanism called reflection. It's a little complex to understand, but if I'm not going to talk about it, but just if you want to read about it, please try to read it, that there can be reflection within a certain amount of tissue and which can cause arrhythmia. But I'm going to talk about these first 3 things. So enhanced automaticity, let's say heart, so the sinus node was beating at a rate, this rate, it can become faster. Just the same thing gets faster, that's enhanced automaticity. Now, how does it happen? Let's look at this action potential, which is the sinus node potential. This is membrane diastolic potential, and because of the funny current, the threshold becomes less negative, and once it reaches the threshold potential, we have action potential. And this is what will decide the rate. We can, for some reason, the threshold can change. Instead of it happening here, if it happens here, like this one dotted line, you see, it gets faster. Or it can happen that the mean membrane diastolic potential for some reason can go up towards less negative, and that will increase the rate. Or I have a change in slope. This funny current can change, and cause tachycardia. And there are different mechanisms. Why will this happen? Sometimes it's totally pathological, that I can have an enhanced automaticity, or like sympathetic tone. What will happen parasympathetic? So if this is the heart rate and there is increased vagal tone, what will happen? The membrane diastolic potential will go down, and it will take more time to reach the threshold, and that will slow down. So that's the mechanism of vagal action. And the reverse will happen with sympathetic tone, that membrane diastolic potential will become less negative. And this is the basic fundamental mechanism how it's happening. And that's why if you look at that, in this area, there is no role of calcium current. And that's why calcium channel blocker will not change heart rate much. On the other hand, beta blockers will. Or if we give drug like ivabradine, that will slow down heart rate. But calcium channel blocker normally does not change heart rate as much. So this is a physiologic enhanced automaticity. A patient with sinus tachycardia. This is the commonest kind of enhanced automaticity, somebody with heart rate of 123. Now, this is somebody that sinus, you can lead 3, and then suddenly I have P wave, which is different. If you look here, the morphology is different here. So this is an atrial tachycardia. The atrial tachycardia, most common mechanism is enhanced automaticity. Now this one, there's a totally new focus that comes up. There is some type of Dr. Azizul, you should turn your camera off. This is the most common mechanism of atrial tachycardia is enhanced automaticity, but also it can be reentry. So what are the types of enhanced automaticity? Supraventricular premature beat, ventricular premature beat, some form of atrial tachycardia, and these two types of ventricular tachycardias, right ventricle outflow tract ventricular tachycardia, left ventricle outflow. These can be of automatic in nature. And after depolarization, so the action potential, this is the action potential. For some reason, when we can have delayed after potential. And also, if this delayed after potential is big enough, then it can cause this another stimulus. And that will cause tachycardia. And delayed after depolarization is calcium. And then we have early after depolarization, which is normally related with long QT. So this thing can happen in long QT syndrome, or if we give antiarrhythmic drug, and they can produce the early after depolarization. And so early after depolarization can become really phase 2, phase 3, and this is delayed. And phase 2 is calcium current dependent, phase 3 is potassium current dependent. And early after depolarization examples are torsade, long QT arrhythmia, delayed after depolarization, arrhythmia of digital age toxicity such as atrial tachycardia, catecholamine. Can you mute everybody, please? Okay. Catecholaminergic polymorphic ventricular tachycardia. This is an important mechanism to understand because it will also tell us how to treat these patients. So this is an example of, this is very common, everybody knows this thing, that there is a patient with a sinus first degree AV block. I don't think this is complete heart block, probably a patient with, and then long QT, there is one premature beat, probably due to after depolarization, and the proof is that it then degenerates into a polymorphic ventricular which is torsade. And the difference between torsade and VF is basically it twists around the point. You can see that the QRS is negative here, it becomes positive, and then it stops. Torsade will terminate. Reentry, how does it happen? So I'm going to take this circle. Initially, this was described in the early 1900s on jellyfish. What they did, they took a tissue of jellyfish, made a hole into and made it like a donut. And then if you introduce an electrical stimulus here, it will go in both directions and they will collide in the middle and then extinguish. Nothing will happen. However, if I can create a block here with some kind of mechanical pressure, and we introduce electric stimulus, it cannot go this way. It can only go this way. And then it will keep coming. And by that time, this part will become, it will be outside of refractory period. And if that happens, if there is an excitable gap ahead of it, then it can continue round and round. Now, the critical part is that there must be an area in front of this electricity which is not refractory, in refractory partial or a complete refractory period. Because if it is refractory, then it cannot conduct. And that's why we don't see this arrhythmia all the time. It happens just at a critical time, when a critically timed premature beat can produce a signal that goes in one direction, and then it can go round and round. And this barrier, now this is a tissue that has been artificially created, but how will it happen in real life? Real life, we can have that. Let's say somebody has the IVC or tricuspid embolus. That's an anatomic barrier. You can have a re-entry around that area, or you can create a functional barrier. This concept is a little different, that you produce an electrical stimulus, it goes inside, make this part refractory, and this acts as a dead tissue, and the re-entry goes around it. It is very difficult to prove, but this is easier to prove. So this is an example of, this is a scar tissue. If somebody has myocardial infarction, you can have dead tissue, the gray ones, and then you have living tissue. Now I have many channels. And what the electricity can do, that electricity can come in through this channel and then go out, produce the QRS complex, and then go around it and come back and continue like this. And this is the mechanism of ventricular tachycardia in patients with history of myocardial infarction. And what antiarrhythmic drugs do is that we give them antiarrhythmic drug, and they make this pathway so slow that the electricity cannot conduct anymore. And that's how you prevent it from happening. Or if I have drug refractory arrhythmia, we can do electrophysiology study, find this place where there is a common pathway, probably over here. And if I can ablate this, if I can block this pathway, then the VT will not happen again. Remember one thing, like if I go over there and block, let's say I go and block here, what will happen? The electricity can go down this way. That's why during EP and ablation, we have to find the final common pathway for this, and we ablate this area. And that's how we produce this block and prevent the arrhythmia from happening. So there is another type of arrhythmia that is, we call bundle branch reentry. So this is the right bundle, left bundle. What can happen that the electricity can go down the right bundle, come back and go through the left bundle and produce this arrhythmia. And this is not uncommon. And we, so this is left bundle reentry, right bundle reentry, and this is reentry over here. So this actually left bundle reentry is fairly common in patients with dilated cardiomyopathy. Right bundle reentry is very common in cardiomyopathy patients. I have one ECG that I would like to show and ask, please look at this ECG, and then if we have a poll, I would like to have that up. Not right now. So please look at this ECG. This is a patient with history of dilated cardiomyopathy, came to the ER with syncope, and this is the first ECG. You can see that there is a tachycardia, and then it stops. We have sinus rhythm. The question is, what is this tachycardia? Can you have the poll, please? We only have two choices, so please choose. Tushar? Anybody available to put up the poll? Can you hear me? Tushar? Tushar?
কামরুল, পোলটা দাও।
This, sir. So we have only two choices. Is it ventricular tachycardia or is it supraventricular tachycardia with left bundle branch block? The beginning part before conversion. Okay. So thank you. So good number of people answered. 9 participants said it's ventricular tachycardia, and then 15 said supraventricular tachycardia. Now, clearly, I mean, the problem with this ECG is that if you look at lead V1, this is before conversion and after conversion, exactly same morphology. Lead 1, same morphology. Lead 3, same morphology. And that points towards supraventricular tachycardia. But the patient's history is a little funny. The dilated cardiomyopathy presents with syncope. So what I did, I expanded this ECG. If you look at lead 1, look at here. There is a P wave and there is a P wave here. And I have expanded it. You can see the P wave over here, P wave over here. And it's not present anywhere else. So there is a possible evo dissociation in this patient. And then, of course, you still have a confusion. And this patient underwent cardiac electrophysiology study. And during electrophysiology, we could induce, this is actually from a book of Dr. Klein. I borrowed it from there. And you can see that the tachycardia could be induced. And the way you find out that this is a left bundle branch reentry is that before each QRS, there is the his bundle electrogram. Unfortunately, there is no atrial electrogram recorded shown in this. And I'm sure if the atrial electrogram was shown, it would end up being there will be AV dissociation. So I mean, this is it. So what's the point of putting this? That the history, context, but the morphology, white QRS, but it was supraventricular tachycardia. So what are the mechanism of supraventricular tachycardia? There are multiple mechanisms. We can have re-entry within the sinus node. We can have re-entry in the AV node. We can have atrioventricular re-entry. That means the electricity goes back through the accessory pathway, comes down through the AV node. But the common thing is that the common pathway is AV node. So if it is coming down the AV node, eventually the QRS will be narrow unless there is pre-existing bundle branch block. So this is one patient, narrow QRS tachycardia, and then you can see that there is a possible P wave immediately after the QRS complex visible in lead 2. And this is most likely AV nodal reentry. This is one of our patients, so it was actually proven AV nodal reentry tachycardia converted with IV adenosine. And the mechanism is that you can have electrical stimulation. Normally it will conduct through the fast pathway, and slow pathway cannot go down because it's already refractory. However, a critically timed stimulus can go down the slow pathway, like this one, blocked in the fast pathway, and then go down the slow pathway, and then come back to the fast pathway and then produce this tachycardia. The reason it blocks in the fast pathway because fast pathway has longer refractory, and then it can continue going round and round until we stop it either by vagal maneuver or any kind of medication. But again, the common pathway is his bundle. So supraventricular tachycardia, common pathway is his bundle. So the morphology of the QRS complex will be decided by the ventricular conduction. If the previous ECG has normal conduction, it will be narrow QRS. If patient have underlying bundle branch block, it will conform to that pattern. The only exception will be if there is an accessory pathway, which I'm going to come, and the conduction is through the accessory pathway, then we can have wide QRS tachycardia, which is a bizarre morphology, and it will produce tachycardia, which almost looks like ventricular tachycardia. So this is another patient with narrow QRS tachycardia. I can see a P wave here. And my feeling was this is an atrioventricular reentry. Clearly, this patient had WPW syndrome, and it was atrioventricular reentrant tachycardia. And the way it happens is atrioventricular electricity goes down through the AV node, his bundle, and then comes back through the accessory and goes around. Because it is going this way, the most of the time, it will be narrow QRS, majority of the, unless there is underlying left bundle branch or right bundle branch block, or if they have rate-dependent bundle branch block. On the other hand, if the electricity is go down this way, then I will have a wide QRS tachycardia, which will be antidromic atrioventricular reentrant tachycardia. This is another common tachycardia that we see, atrial flutter, typical atrial flutter. And what happens? Atrial flutter, there is reentry. The common typical flutter goes between, the electricity goes between inferior vena cava and tricuspid annulus and produces the tachycardia. And that's why we can ablate this narrow zone. And interestingly, typical atrial flutter is more common I have seen more in America than in Bangladesh. Bangladesh, we have more atrial fibrillation. And then we can also have reentry around scar tissue. Like this is the common mechanism, the common tachycardia that we will find in Bangladesh. People who had atrial septal defect had surgery and they had an incision line, and you can produce this incisional tachycardia. There is scar tissue that produces a barrier, and then you can have reentry around it. And the way to do it, ablation that we do, there is a narrow area between this scar and the IVC or tricuspid annulus. Then if we just ablate that area, we find the common pathway and you can fix it. I'm going to just talk about these drugs, how it works. Like we have 4 categories of drug: sodium channel blocking, which is disopyramide, quinidine, and procainamide. Not much used. We have class 1B drug. These are sodium channel, lidocaine and mexiletine. Mexiletine actually is a very good drug to use because it doesn't have any effect on myocardial contractility. So if somebody has cardiomyopathy, it doesn't prolong QT, it can be used. And then, of course, we have class 1C drugs, plecanide and propafenone. These are not for ventricular arrhythmia. These are for atrial arrhythmias in patients with structurally normal heart. And then beta blockers, and the potassium blocker, sodium, amiodarone, and sotalol, and the calcium channel blocker. This is interesting that if you look at this, how these drugs work. If we look at class 3 drugs, these are potassium channel blocking drugs. Ranolazine, this is a sodium channel blocker. Even though it's an anti-anginal, ranolazine is also found to be effective in patients with atrial fibrillation. And then digoxin works on this sodium-potassium ATPase. And this NCX drugs, exchanger, amiodarone has some effect on this channel. And there is a study going on to produce a drug which will block this and enhance myocardial contractility. Look down here that we have drugs like class 2 drug, beta blocker. It works in this, C beta blocker in this channel. Anticholinergic drug, so potassium, acid and choline dependent potassium adenosine works there. And then ivabradine works on the funny current. And then if you look at the calcium channel blocker, it works on the calcium channel. So these are the different ways. And there are drugs, they're now developing drugs which will work inside in the mitochondria to increase contractility or work on cardiac arrhythmia. I think I'm going to stop here. And we'll take any questions if we have. Thank you. What I will do is that next week, I will continue with, if you permit, that the EKGs on wide and narrow QRS.
Sure, sir.
One question that comes in.
Yes. I couldn't hear you. What the...
I think, sir got disconnected.
Yes.
Sir, in the meantime, I just want to ask one thing, sir. If for a center where there is no known electrophysiology setup or known electrophysiologist as per se,
Mhm.
so treating every white QRS tachycardia as VT and then go back to review the ECG after the QRS becomes normal or the ECG becomes normal. Is it the wiser approach, or if a patient comes there and they start to analyze the ECG first, what
Oh.
will be the easier approach?
Okay, so let's start with a simple ECG. I'm going to go back. This patient, narrow QRS tachycardia. If this patient is hemodynamically unstable, this will be treated same as VT. So the reason I'm bringing up this point is the treatment of the arrhythmia should be decided by the clinical scenario of the patient. If somebody, irrespective of wide or narrow QRS, if they're hemodynamically unstable, then you treat it urgently. On the other hand, if somebody has a wide QRS, I had patients with wide QRS tachycardia, known ventricular tachycardia with a heart rate of 140, hemodynamically stable. I will give them medication to try to see if I can convert them. And then if not, then I will call anesthesia, take my time, and do cardioversion. So to summarize, it's not the arrhythmia, it's how it looks. What is the clinical stability of the patient, which will decide how we treat this person.
Thank you, sir. Thank you again, sir, for the excellent delivery, excellent presentation. And as you say always, that knowing basic is very important before going the understanding of the ECGs or anything. In this lecture, you have shown us the basic things that leads to arrhythmias. I hope that the next class you will show us the practical demonstration of what you have shown here. And it's very necessary that we correlate the academic things with the practical things. Thank you very much, sir.
Sure. Thank
We
you.
are eagerly waiting for your next class.
All right. Thank
And,
you.
Hopefully, the second Sunday of the next month,
Sure.
we'll meet again and have the lecture sessions. Thank you, sir. Thank you very much. Thank you, dear participants, for attending this session. And thank you, Beximo Pharmaceuticals, for constantly providing us the scientific support. Thank you very much.
এই তুষার আজকে নেটওয়ার্ক এত খারাপ কেন?
স্যার, এটা সব জায়গাতেই সমস্যা হচ্ছে, মানে বারবার
30% টাইম খালি ঢুকতাম আর বাড়াইলাম।
না, আমার স্যার, আমি তো 3টা জায়গা চেঞ্জ করে তারপরে এটা করলাম।
ইম্পসিবল ব্যাপার হয়ে গেছে। একটা মানে এত ইম্পর্টেন্ট একটা ক্লাস এনজয় করতে পারবো